Welcome to Voices in Value-Based Care. I'm Beth Houck. Thanks for tuning in. The movement to value-based care is revolutionizing how healthcare providers get reimbursed for delivery of care. In this program, we're going to explore stories from the field about how real organizations are dealing with this change. You can follow the show on Twitter at #VoicesInVBC and follow me on Twitter at BA Houck. On the program today, I talked to Craig Law, president of Delaware Health Net, headquartered in Delaware, but with member organizations across the country. Craig and I are going to be talking about how social determinants of health are impacting performance in a value-based care world. So excited for this conversation because I know Craig has lots of interesting stories and things to tell us about. So Craig, welcome to the show.
Thank you for having me, Beth. Look forward to it.
Well, Craig, maybe you can do a better introduction than I can. Why don't you just tell the audience a little bit about yourself, what your background is, as well as what your role is at Delaware Health Net.
Okay, sure. I'm the CEO of Delaware Health Net, and we are what's known as an HCCN. It's a health center controlled network. We work with FQHCs, federally qualified health centers across the country, and we've focused the past 5 years on clinical quality improvement activities, and we work with a total of 17 organizations in 8 different states. And besides running the Delaware Health Net, I also have a healthcare consulting firm and a medical billing company I run.
So, and in your spare time, you do podcasts.
That's right.
Right?
That's
roughly,
right.
You said how many states? Broadly, how many clinicians approximately does Delaware Health Net?
Yeah, so amongst the 17 organizations, we're in 8 different states: Washington State, California, Minnesota, Ohio, North and South Carolina, and New York. Across the country, we work with over 500 physicians, and under the care of the centers is 1.4 million patients. So it has a good, strong footprint. And the thing that really makes us somewhat unique is that even though we deal with the medically underserved and uninsured and Medicaid patients, we've had tremendous amount of success with getting our providers to be able to attest for meaningful use. In fact, 80% of our eligible physicians have been able to attest for meaningful use stage 2. So we've been really excited that regardless of where our centers are, and some are in very urban areas, some are in suburban areas, we have rural, we have a center that's near frontier-like, but we've been able to have great success in impacting all of those different locations.
That's really interesting. Do you find that the geographies learn from each other, or I should say the centers, because of their geography, learn from each other?
They really do. You know, a community health center is very community focused, very local. And so each organization has their own challenges, but when they can start talking about those challenges, they start learning about the unique things that another group's trying. So it's a real sharing process.
That's great. Well, I guess we're going to hear more about some of that sharing as we dig in here. So I don't know how long, and perhaps you even know this answer, how long the terminology, social determinants of health, has been around, but the concept certainly has been around forever. But I think that now that we have data centralized and more ways to measure how things are impacting healthcare, I think there's a way for us to put a name to it and a way for us to really quantify what the impact is on social, what the social determinants of health are and what impact they're having on people's healthcare. I know that you speak on this topic and you really have dug into it. Can you give the audience a little quick primer on what the social determinants of health are?
Sure, Beth. It's as simple as really the condition in which people are born into. They grow into, they live in, they work in, and then they age. And it's really the circumstances that are shaped by money, power, and access to resources. And, there's different areas of social determinants of health. There's the economic side of things, there's the physical environment, and then there are health behaviors. Those are kind of the 3 tall rubrics. And what we've learned over the past decade or so that people have been really starting to look into this is that only about 20% of health outcomes are affected by medical encounters. The other 80% of health outcomes are driven by the environment. And so by looking at it, we've found that 40% is impacted by economic factors, 10% by somebody's physical environment, and 30% by health behaviors. And by starting to look at that on an individual person-by-person basis, all of a sudden we're getting huge enlightenment as to how to help an individual. You know, it's not, we used to talk about population health, and we still do. We still focus on populations, but this really gets to the exact reverse, looking through the mirror in the other direction and saying, what individual issues does an individual patient have that can be helped, maybe not by a pill, but by their environment, and how we can link them up with social services that will help them.
That's a really amazing statistic, the 80% statistic. That's incredible. What data, I mean, I know you as an organization, have lots of technology and you're using that technology to help make decisions, but even just more broadly, what data is available to help define more or give more detail to some of those issues in particular geographies? Is there kind of resources available that the organizations can use to determine what's going on?
Yes, even if you just Googled SDOH or SDH, you'd probably be able to find the resources out there. But the National Association of Community Health Centers has had a project going for several years to really identify what are the key drivers for expense, cost, and health outcomes. And so they've really honed it down to 16 items that are useful to know about your patients, and depending on the answers to those, potentially 4 more things. We look at race, we look at ethnicity, look at migrant and seasonal farm work status, veteran status, language, the housing status or their housing instability, the neighborhood they live in, the education level they have, their employment, insurance access, their income, material security, access to transportation, social support and integration, and their stress levels.
Oh my gosh.
16 items.
It's pretty incredibly long list of things that can impact, which makes this the challenge, but at least they're identified, like having that list of 16 is at least the start. You and I have had conversations over the years about how ahead of the game FQHCs have been. I think for those listeners out there that don't deal on a regular basis with federally qualified health clinics or don't know some of the requirements, federally qualified health clinics have had to report quality data for years and years and years. And they've been measured against the reporting of that quality data for years and years and years. So what I find kind of interesting is that it's, in a way, your kind of, or the National Association of Community Health Centers is really leading the charge on cracking this social determinants of health nut, but yet the application of that solution might be more broadly accepted because it's really important for value-based care. So if you're going to be trying to bend the cost curve, you're going to need to know that sort of thing. Can you expand on that a little bit? Am I off track, or am I kind of in line with how you think about this as well?
I think you're hitting it on all cylinders. We have been tracking quality data for so many years. If the Meaningful Use program was for private practice, it's sort of a wake-up call that we need to start looking at this. We've been doing it for decades, and so it certainly is. Even though our population is tremendously challenging because they have these social determinant of health issues that they're dealing with, it really does allow you to individualize it, and it really has made us change the way we look at patients from just the reactive side of having a patient come in, they're sitting in front of you, what can I do to help you, what seems to be the problems, and responding to data points that we collect, like a blood pressure or person's weight or height or something like that, and become more proactive, start asking the questions and start getting creative with what other things, kind of enabling services we can provide to patients and be able to help their situation.
I think things start to get really interesting when people talk about proactive versus reactive. When I was at HIMSS, not too awful long ago, there were so many interesting technologies that were all around being proactive, having something that, predicts that you're going to have an episode or predicts that you're going to get sick or give some sort of advanced warning so that you can cut it off at the pass and not have a whole bunch of consequential expensive care. So I'm super intrigued by that. I'm also super intrigued by how the market catches up to all of that and finds a way to basically pay for it. So so kind of broadly, let's shift to like some examples. Let's talk about some of that good stuff and would love to hear some examples to support the levers of the social determinants of health.
Sure.
Hey, Beth. Sorry to interrupt, but there was the recording kind of blipped there. So can you just repeat that question so we can start over?
Oh, sure. I'm glad you're just asking me to repeat the question because I'm not sure what else. I wouldn't have remembered the other part. Okay. Craig, can you tell me a little bit more about some of the examples of initiatives you've put in place to support the levers within social determinants of health to bend that cost curve?
Well, sure. Let's use a quick example from a provider who gets a patient result that comes into their center because the patient was in the ER a week ago. And so they've gone to the ER. The doctor can see that the patient was there because of a hypoglycemic attack. So the physician asks some questions about patient's overall background, and he learns that basically he had run out of his food stamp money. And so the cost for that ER visit could have been avoided with access to a food pantry. And so you put that linkage in, you have that, on your rapid dialer in your phone so that the patient can access things that would have been able to prevent or will prevent future expense.
So do the communities themselves, let's just take that example, do the communities themselves already know where all of those different resources are, or because of this connection that's been made, they've built up their networks so that they can put some people on rapid dial?
Yeah, the FQHC world really does kind of lead in this because we do see patients primarily who are at or below the poverty level. So we already have the list of those social services that are available, those linkages, and have them in place where a private practice might not have it, but certainly can pretty quickly be able to put those together. If nothing else, going to a local FQHC in their jurisdiction and asking them for the list would be a big jump. But we see all sorts of examples of where huge costs can be contained. We ran into one ACO who had a particular asthmatic teen who was one of the most expensive patients on their roster, and they just were having a devil of a time and spending enormous amounts of money on inpatient care. And the social worker who went to go see this particular patient found out that they were living in a housing environment that ultimately wasn't as useful as it could be, and they needed a new roof. So she worked on getting donations from community services, getting Habitat for Humanity to come in, get the new roof, be able to clean out the wet, moldy fiberglass that was up in the attic, and amazingly, the cost started to drop. So it can be things that do affect your health care and your medical condition and your asthma, but it might be something completely different that has nothing to do with medicine that can bend that cost curve for the patient.
I love hearing stories like that. Sorry that we can't kind of figure out how to do that at scale, and I think that's part of the challenge, but really, kind of even small successes are amazing. I recently heard about an initiative, and I don't recall where, but an initiative with a Medicare population where there were services to put in handrails at a bunch of houses in scale, so there's a contract to put in handrails to simply reduce falls because they found that part of the reason was the lack of handrails or lack of steady ones that were causing a significant amount of overhead cost in the system.
Exactly.
So you have, now I've already forgotten the number, but such a huge number of clinicians and patients and those practices. I know from working with FQHCs are incredibly busy. You know, everybody, the need is still very high. How do you start to both educate clinicians about all of this, as well as get them to figure out how to participate, how to really get them engaged with initiatives that can help support on that side, how to help them, give them the tools so that they can help you on the prevention cycle?
Yeah, I think it has to do with really changing your mindset and looking more at the public health side of things for individual patients. But really what you're talking about is being able to get the clinical support staff to ask the questions of the patients, to get that information about them so that the provider has that data at their fingertips to know what's going on with this patient. If you are prescribing a cardiac medication that costs $150 a month to somebody who has housing instability and food instability, then that's going to fall way down on their list of needs, and they're never going to get that medication filled. So the provider needs to know what those barriers are going to be for a particular patient.
Is there data or fields in the EHR or other ways for that kind of information to get in front of providers?
Absolutely. Most of the EHRs out there have under social history all the kind of items that we're talking about. Some of the EHRs have actually developed, standard templates that you literally go through your social determinant of health list for the provider and be able to set up flags so that the provider knows the particular challenge a patient has.
Excellent. That's great. So how about Delaware Health Net? Are you starting to do some data mining in order to figure out what you can do on scale, or where I guess the biggest hot buttons are?
Sure. Each one of the FQHCs has their own particular issues. If you have an area that's in an urban setting, they have one set of issues. If you might be that they're in a food desert where fresh fruit is just a real challenge for them. If you're talking about somebody in a rural environment, it might be just access to any care. That might be the particular barrier, or transportation issues if you're homebound in a rural area. So certainly we have been collecting that information and we look at it, but it's always on an individual case, other than doing the quick data mining to say what are our top 3 determinants that we know we need to have enabling services to help match. Transportation usually is on that list. Food is usually on that list.
So big challenge is how to get some of this stuff paid for, of course. So lots of work around these initiatives are going to require some kind of upfront investment, and it's sometimes preventive, right? So people having fresh fruit over a period of time means they're going to be healthier. At least that's what we're told. So how do you justify some of the expenses and resource use on these initiatives that might not have any gains until the little bit longer term?
Well, think what we've already got in place today. Depending on what state you're in, I'll use Massachusetts as an example, you already can get differential payments by having proof of incarceration status, homeless status, interpersonal violence status. Those information are able to be negotiated into the rates so that you receive a much higher rate based on those things. Medicare Advantage, they already changed their capitation rates for poverty levels. So those things are already starting to happen. Even though we collected the data to try to find out how it was going to impact our individual patient-by-patient results, the reality is that when an ACO comes in and wants to work with a particular group, we have all this data now to be able to share with them and say, here's why our patients are more expensive, and here's how we can share in those savings if we can figure out how to cut costs together. You give us a little bit more for things like an extra piece of equipment this particular patient needs to keep them out of the hospital, and we'll work to make sure that we get them in to be seen on a regular basis.
I love that. It's this alignment with how you're going to get paid and what you can negotiate to share in the upside of improving the cost equation that is really, I think, going to help people do the right thing or have the resources to do the right thing. So that's excellent. Are you seeing some markets a little further ahead just in their thinking than others, or is it fairly broad at this point?
I think we're all still in learning lab mode. We're collecting this data, and we really have to segment out those who are real serious determinant issues as opposed to the ones that are just, they don't have as much of an impact. So we're still in learning mode, but the payers themselves are increasingly open to those negotiations, those discussion, and when you can identify your populations, certainly in the shared savings arena.
That's excellent. I love hearing that. So for organizations that need to impact these social determinants of health, so now you're giving advice to a health system that's kind of recognizing that, wow, this is really what's having an impact on my cost equation, and perhaps they're in an advanced alternative payment model, an ACO, and they're struggling to figure out where to make changes in order to improve. What kind of advice would you give them?
That one's simple. You've got to collect the data.
Yep.
It's a mind shift. It's going from looking at the data points of medical issues and realizing we no longer can, categorize our patients' complexity based on their diagnosis and how many medications they're on. It's their total social environment. And by making that leap, by collecting that information, then you have the data you need for negotiations with payers, to be able to look at your own cost structure, for health systems to look at closely and say, how can we impact these things? Recently, Baylor is in the process right now of publishing an article that showed they were able to reduce hospitalization costs for their patient population by looking at social determinants of health by over 50%. And when you start seeing impacts like that makes an enormous impact to the bottom line.
Wow, that is an incredible stat. Well, Craig, thank you so much for your time and for all of your thoughts and perspectives. It's enjoyable both to hear them and have our audience be able to share in them, but always really nice to talk to you. You can learn more about the show on the programs page on healthcarenowradio.com and lend your voice to the conversation on Twitter at #VoicesInVBC, and be sure to follow me on Twitter at Beth Houck. I'm Beth Houck, bringing you the voices in value-based care you should hear. Until next time, have a great week.